Welcome, everyone. This is Julia Haney at the Michigan Public Health Institute, and we are delighted to have you all on the line today to hear about where our Title V maternal child health needs assessment landed. We're really excited to share the journey that we've been on over the past year and what the next steps look like. So thank you again for being here today. I'm going to give you just a couple quick notes on Zoom. So we have a couple bars that you can see on the slide in front of you that highlight some key features of your Zoom screen. You should have a bar that on the very left side has a mute button. If you could please make sure that you stay muted throughout the presentation unless you're asking a question or intend to talk, just so that we don't have any accidental background noise, that would be wonderful. Also a reminder, if you are dialing in through your phone, please do not use the hold function on your phone. Use the mute button instead. The hold function will lead to us hearing background noise in some cases. People's delightful infomercials and music and such. So if you could not put us on hold, that would be wonderful. But please do keep us on mute, either on your phone or through the Zoom interface. You'll also see on that bar a chat box. And we invite you and encourage you to use that chat box throughout our session today to chat with the group as a whole or chat with us directly. If you're experiencing any tech issues, we can try to sort those out that way. And of course, if you have questions, comments, things that you want to contribute to our conversation, you can do so through the chat box as well. I also want to mention that the slides for today's presentation are uploaded so that you can access and download those through Zoom as well. So with that, I'm going to turn it over to Dawn Shanafelt to kick us off this afternoon.
All right, perfect. Thank you, Julia. And first off, I'd like to echo what Julia had just said, but I'd like to thank you all for being part of our webinar today, and thank you for all of the time, effort, and expertise that you shared throughout our Title V maternal child health needs assessment process. So our agenda for today is to discuss an overview of the needs assessment process, including the entire process and goals, and then an overview of mobilizing for action through planning and partnership, or our MAP assessment and findings, share the state priority needs and performance measures with everyone, and then discuss next steps. So with that, we're thanking you in a variety of wonderful languages. And at this time, I'd like to turn it over to our maternal child health coordinator, Sarah Davis.
Thank you, Dawn. So I am going to quickly reorient us to Title V, just to give some context, because I know for a few folks, it may have been a few months since any of the population domain meetings or any of the other needs assessment activities. So just a quick reorientation to Title V and the needs assessment process. So you can see some details on this slide about the Title V MCH block grant. It is administered by the Health Resources and Services Administration, or HRSA, and so you may hear that term used today several times. And you can see from the vision and the mission and some of the other bullet points on this slide that the population served through Title V includes women, mothers, infants, children, adolescents, and children with special health care needs. Awards are given to 59 states and jurisdictions, and one of the core requirements related to Title V is what is known as the 30-30-10 rule, and that essentially means that a minimum of 30% of Title V funding must go towards services for children 1 through 21, and a minimum of 30% of funding must go towards services for children with special health care needs, and then lastly, that no more than 10% of a state's Title V award can go toward grant administration of the actual grant itself. And then again, just to quickly share the way that Title V supports MCH work in Michigan. You can see several areas and initiatives listed out here. In Michigan, the largest single allocation of Title V funding goes to local health departments for their local MCH or LMCH work. That's about 37% of Michigan's Title V grant. Also, as discussed in the previous slide, over 30% of Michigan's Title V grant goes toward direct medical care and treatment for children with special health care needs. And then there's also an array of other initiatives that Title V supports, including childhood-led poisoning prevention grants, reproductive health initiatives, immunizations for children and adolescents, oral health for children, and other maternal and infant health initiatives. So again, that was just to share a very brief overview of Title V in Michigan, and now I'm going to hand it over to Julia to give us a quick debrief on the Title V needs assessment process before we dig into the findings.
Thank you, Sarah. So the Title V needs assessment gives the entire maternal child health system as a whole this awesome opportunity to step back from the everyday implementation of programs and services and look at the big picture, to wonder together about what's going really well, what are the strengths of our system, what can we build on, and where do we have gaps, what's emerging as a concern, what longstanding concerns do we need to talk about because we haven't figured out a way to address them yet. So the needs assessment process, beyond its kind of application to Title V, gives us across the maternal child health system just that opportunity to stand back and learn and be reflective, explore, and that's really what we did over the past year. So every 5 years, Title V grantees complete this maternal child health needs assessment. In the context of Title V, those results are used to select 7 to 10 state priorities for the next 5-year cycle of the Title V block grant. And again, in the context of Title V, those priorities are aligned with federally identified national performance measures and state identified performance measures, and then state action plans are developed to improve performance on those selected measures and to address state priorities. This same kind of stepwise process can be followed outside of the Title V structure as well, around other MCH programs and services that aren't necessarily Title V funded, but can benefit from the story of need and asset that's generated through this much broader maternal child health assessment process. On the next slide, you see a cycle. And this lays out the general steps of a needs assessment. It's based on the public health planning cycle, which is something that appears in the Title V guidance. And for us in this year-long process, we pretty much are through step 4 and diving now into the fun of steps 5, 6, and 7. But I think that the image of a circle here connotes something that's maybe a little bit more stepwise and linear than how this process actually unfolds, where we're even between the cycles of needs assessment, the big needs assessment every 5 years, we're seeking information that helps us understand our context, learn what's going on, and make improvements and programs and interventions based on what we're learning. So while this kind of lays out what the big 5-year process looks like, there's little cycles of this happening on an everyday basis and on an annual basis in order to make sure that we're doing as well as we can to serve the women, mothers, infants, children, adolescents, and children and youth with special health care needs in Michigan. The Title V needs assessment, the maternal child health needs assessment, was guided through a couple kind of principles that we built based on the last 5-year cycle's needs assessment. We wanted to make sure that this needs assessment had explicitly a health equity and health disparities lens, that we built concepts of equity into each phase of the needs assessment process. We wanted to make sure it was a data-driven approach, and by data, we wanted to be inclusive of multiple types of data, both our quantitative population-level data and the wisdom and experience and voices of people who work in maternal child health and who live within this state and experience the programs and services and conditions that we work to address through our maternal child health system. We also wanted to have diverse stakeholder engagement. We wanted to widen out beyond the folks who work in maternal child health at the state to our broad system partners across the state, as well as to community members within the state, to be a voice and a part of this process. The purpose of the needs assessment was to identify the strengths and needs of the MCH population, including children with special health care needs, to improve the health of the MCH population. Ultimately, this process will lead to identifying state priority needs and performance measures for Title V for fiscal year 2021 through 25. But again, we also want to identify opportunities to address needs that fall out of the scope of Title V funding and our needs for the MCH population more broadly. So with that very quick overview, I'm going to dive into how we gathered data and information to understand needs and assets for maternal child health in Michigan. We use the Mobilizing for Action through Planning and Partnerships model. This was developed by the National Association of City and County Health Officials for local health departments, and it's a process that our local health departments across the state are pretty familiar with, and we thought we could build on that as an asset and think about how it applied to maternal child health at the state level. So we have 4 assessments that I'll speak to in a little bit more depth as we go through them, that we use to generate information: our health status assessment, our community themes and strengths assessment, our public health system assessment, and our forces of change assessment. So we'll start out by looking at our system assessment. So the intent of this system assessment is to look at how our MCH system as a whole, how our maternal child health system as a whole operates around 10 essential services. Those 10 services you can see listed on the slide, and you'll note that we have data findings related to 6 of those 10 assessments. At the beginning of this process, we realized that we probably wouldn't have the capacity to dive into all 10, so we prioritized those domains based on where we felt like we really needed system input to understand where our strengths were and where our gaps were. So we focused on those 6 as a starting point, with the idea that if we found the system assessment beneficial and valuable, that we could, in the intervening time between this assessment round and the next assessment round, maybe we could dive into some of those other areas as well and see what else we could learn through this type of approach. But what we did was we convened approximately 50 individuals from this Title V stakeholder group and others to participate in this assessment. Participants broke up into groups to talk about these essential services. They had a series of prompts that they went through, and they made a rating around where they felt like the system was performing in each of these areas. Overall, we saw that the highest rated area was how we in MCH link people to personal health services, and we saw more gaps in the area of evaluating our effectiveness and creating systems of accountability across our programs and services, so that essential service 9. But of course, if you look at those ratings, they're all really close to each other, and they're all telling us that we have somewhere between minimal and moderate activity, suggesting that we have some strengths to build on, but we also have some gaps in how our system is functioning that could be a space for improvement, development, attention in the work we do in the future. The real depth of this assessment is in the conversation that's generated around each of these essential services. So the discussion that we have about how do we educate and inform people about MCH issues and needs, how do we develop and implement policy, how do we evaluate and support quality improvement. In each of those areas, we had really rich conversations, and those conversations were captured, themed, and they are included in a system assessment report. A couple of the findings are highlighted on this slide. For the sake of time, I won't be able to read through each of the findings, but once the report is finalized and posted, I really encourage and invite you to dive in and see which of those findings resonate with you, align with your work, create a space of opportunity within the work that you do. But a couple of the things that we heard about many efforts to disseminate information to communities. For example, we heard of lots of examples of programs that are developing materials, developing messages, have websites, have campaigns, and so forth. But we also heard that messaging could be more consistent, it could be more coordinated, it happens often in silos, and that it could be more informed by the people that we're serving and more inclusive across population groups. As another example, we heard about lots of efforts to raise awareness about the root causes of disparities, and that there's lots of discussion about equity that's happening in the maternal child health space. But we also heard a concern that we're not doing as much as we could to translate that learning into changes in how we develop policy, administer programs, implement services, and so forth, and that there's more opportunity to learn and do in that kind of space of how our system is functioning. So again, the final report out of this assessment will look at findings both overall and in the space of specific population domains. And again, I really encourage you to jump into that report and take a look at all of the details of what came out through this process. So our next assessment was the Forces of Change assessment, and this assessment looks at trends, factors, and events in our the broader context of the world that we live in and the work that we do that might influence the health of women, mothers, infants, children, adolescents, and children with special health care needs, both in the recent past and the foreseeable future. So we want to look at the broader context of our work and notice those things that are going to impact the health of the populations that we serve and bring those into our thinking about our programs and services, our policy work, and so forth. So this, again, was completed by about 50 individuals from this Title V stakeholder group, as well as others who were invited to participate in the assessment. We organized this assessment by population domain, as well as having a cross-cutting domain, so that the conversation was specific to mothers, infants, and women, specific to children and adolescents, and specific to children with special health care services, as well as one that was really broadly across all population domains. Again, in the full report out of this assessment, you'll see the population domain specific findings as well as kind of overall findings. And this slide just highlights a couple of the things that we saw kind of overall through the Forces of Change assessment. One example of something that came out of this assessment especially was around how pollution, environmental toxins, and climate change disproportionately affect vulnerable populations. That was a concern raised by participants in this group. We also heard quite a bit of conversation about how poverty impacts health and how the forces that drive poverty are driven by kind of multiple places, but one of the places that we're noticing it and seeing it is in creating increasingly restrictive eligibility requirements around programs that are really important to families. So again, we have many other findings that are similar to that are really looking at how the world that we live in impacts the population we serve and might in the future have more impacts, either for the health of the populations we serve or adversely affecting those populations. Our third assessment is the Community Themes and Strengths assessment. And this is the assessment where we went out into our communities and listened to both professionals who work with the MCH population and community members themselves, family members, adolescents, about their experiences around health and well-being, the forces that promote health within their communities and the forces that make it hard to be healthy, hard to stay healthy, or hard to reach your potential for health within your community context. This assessment included 526 responses to a provider survey, 307 encounter surveys, and 20 focus groups. And we'll look a little bit more deeply into what we learned from each of those. This slide actually gives just a little bit more detail about what we were seeking to learn through each of these data collection methods. Our focus groups and listening sessions, the questions under those really looked at what participants felt defines a healthy community, the assets and strengths that they see in their community, the unmet needs that they notice, healthcare access concerns, and health equity and potential solutions around creating greater equity and health in our communities. Our encounter survey asked folks receiving services to think about what influences their health and well-being through questions about strengths, barriers, and potential solutions. And our provider survey reached professionals who serve families across the population domains to identify unmet needs impacting the population that they serve, as well as questions related to healthcare, basic needs, and questions around equity. We have a couple slides that just share a few of the quotes that, that came out of these data collection methods. So from our focus groups and our listening sessions with families and community members, as well as providers, we heard about social determinants of health quite a bit through these methods. And here's one quote that illustrates that. The social determinants of health, we talk about it and how important it is going upstream. It's so big, where do we even begin? So we heard a lot about that, acknowledging of the factors in people's lives that impact their health, how critical it is to look outside of healthcare, however, how overwhelming that can be from the perspective of a service provider, a person working within our system. Another quote, so far as what is health, being able to get what you need when you need it and get it easily, because those are the barriers that we have. So when people were asked to talk about health, they weren't just talking about physical health, but they were talking about well-being, and they were talking about the forces that that create the opportunity to be healthy within communities and within systems of service. These pressing needs are the things that could change the way someone grows up. And again, this is kind of related to thinking about social determinants of health, thinking about the impact of that over the life course on people's opportunities to be healthy. And finally, you can only make choices depending on what choices are available to you to make. So again, that acknowledgement that that context plays a huge role in health outcomes, especially when you're looking at health outcomes over the life course. We have a couple of quotes also from the Encounter survey. So again, this was completed with either, I don't actually think I said this, adolescents who are being served by our child and adolescent health centers, by folks who are involved in children's special health care services through their networks of engaging parents in their work, and through maternal child health providers, home visiting service providers, reaching families, women across our state through the Maternal Infant Health Program. So through those surveys, we have a couple of quotes here as well. They identified support such as services that provide well-rounded programs and opportunities like education groups, kids, families, and such as playgrounds, classes at farmers markets, flyers about health and wellness. We saw actually quite a bit around the community assets and resources that support health and well-being, and how important that is to children and families. We saw some areas for improvement, of course, as well, and here's a quote that reflects one of those: awareness of what resources exist, how to contact them, and what the limits are within those resources. We heard quite a bit about kind of the invisibility of services and how difficult it is to even know what they are, much less figure out how to access those for yourself or for your family. We also heard about barriers such as the cost of childcare, finding a reliable daycare. Some jobs are not family friendly, hard to care for kids and fulfill job expectations, such as work hours not being flexible. So we heard some of the policy, cultural, economic barriers to raising healthy children and staying healthy yourself in the context of our communities. Going a little bit into the quantitative data that we saw in the provider survey, again, all of this will be explored in much greater detail in the report out of this process itself. But in the provider survey, we asked about what providers noted as the basic needs that go unmet most often among families that they serve. And as you can see in this graph, reliable transportation and quality housing really stood out as being especially of concern for the folks served by the providers who responded to this survey. But I would also note that there's really a different pattern among children with special health care needs, the providers that serve that population, that there's some differences in what they saw as needs. For example, social support really stuck out as a need noted among those providers, and that really aligned with what we saw in some of our qualitative focus group data as well. In the provider survey, we also asked kind of separately about which healthcare related needs are most often unmet among families that they serve, and really it was mental health care that across population domains stood out as an unmet need for the families that are being served. With, again, for children with special health care needs, care coordination and case management really sticking out as a unique need for that specific population, as noted by the providers who responded to this survey. Across the data that we collected, we have findings that are related like overall and also to each specific population domain, and we have a lot of data and a lot of findings, and I really wish I could dive into all of the details today, but we just don't have quite enough time for that. So again, look at that report, dive in, see everything that we learned and discovered through this process. But here on the slide, you can see a couple of our community themes and strengths findings that are specific to the child and adolescent health population that we want to highlight. So for example, for children and adolescents specifically, it's that the education system came up as a powerful space of opportunity for health promotion, as well as threats to health that are experienced by children and adolescents across the state. So really highlighting the importance of collaboration and partnership with education. We also had findings here that were really related to safety. That was something that came up especially strongly in the data collection around children and adolescents, with adolescents reporting that they are especially impacted by bullying, social media, violence in their homes and communities, and the space of impact of that for them is on their behavioral health and their mental health. And that's something to pay especially close attention to. We also heard important needs related to children and adolescents in the space of oral health and oral health care. We heard about provider shortages, geographic disparities, and available dental services that impact this population, and the need to focus on reducing those gaps in dental services. That was really echoed in thinking about behavioral mental health care services, of having challenges in accessing providers and especially in specific areas of the state. Again, just to highlight a couple of the findings related to children with special health care needs. With this population domain, we heard quite a lot about the shortage of providers and other similar barriers to receiving quality, timely, and equitable care. We heard concerns about access to medication and services, specialty care providers, differences in access in different parts of the state. That sort of finding really emerged for this population group. We also heard quite a bit about the need for respite care for families and children with special health care needs, which wasn't something we went in to look for or ask about, but something that we heard about through the conversations related to children with special health care needs. For this population, we also heard some strong similarities with what we heard in our other groups related to noticings around health equity and disparities, that racism, discrimination, and implicit bias are impacting health outcomes and driving disparities. We heard about the desire for greater community engagement, connectivity, and communication, greater social support, and opportunity to be with others in community. And that was something we heard about from the other population domains as well. The next slide highlights a couple of the findings related to women, mothers, and infants. And in this, for this group, we also heard quite a bit about the role of racism, implicit bias, discrimination, and restrictive policies as challenges that are facing women and mothers as they seek to access services before, during, and after pregnancy. We also heard quite a bit with this population domain about the role of adverse childhood experiences on the mental and physical health care of children as well as their parents and those that care for children. In this assessment, we also heard a good bit about safe sleep and breastfeeding and the role that they play in health and well-being, and the need for additional support and education on these particular topics. Gosh, I feel like I covered that very quickly and covered at a very high level. There's so much more to see and to learn from, and we'll be in the Title V process carrying a lot of that learning forward, but hope that all of you as well can look at those findings and see what's valuable and informative to you in your work and in your communications with the people that you serve and the funders that you work with and partners that you work with and so forth. So the fourth assessment is our health status assessment. And this assessment looks at a whole lot of indicators of population health across each of the population domains. And you can see the numbers here on the slide. That we started the process by looking at 59 health indicators around child and adolescent health that had enough data that we could use it for this assessment. Our wonderful state MCH EPIs actually looked at a broader group than that and narrowed it down to this 15 that we could use and ended up pulling 12 health indicators into the assessment itself. In women, maternal, and infant health, we looked at 57 health indicators with adequate data for assessment and pulled forward 12 of those. And for children with special health care needs, we started with 100 health indicators for the assessment and pulled forward 15 to give special attention to. On the next slide, you can see how we made choices about which were elevated for special attention as part of this assessment. Our EPI staff looked at those indicators where we saw a high and or worsening disparity between our Black population and white population. One of the questions that we had, of course, was can we look at more racial groups or ethnic groups than Black and white? And we have some data limitations around that. And also, we see some similarities, not identical, but some similarities in patterns between the Black-white comparison and comparing other racial and ethnic groups. So for this round, this was where we landed, is focusing on those indicators where we saw a disparity. We also looked at indicators where there was a worsening trend over time. Of course, we could only do this if there was enough years of data that we could look for a trend. However, if we saw that trend, we pulled those things forward. And we also looked at where Michigan's performance was worse than the U.S. overall value within that most recent year. So we used these criteria to kind of narrow down which indicators we would look at in order to kind of focus our attention on those areas of health where we had especially high concern about where we sit as a state. I'm going to pause there for a second and just ask if there are important points about our assessment process that I overlooked, anything anyone else here in the room wants to add to that conversation.
Thank you, Julia. This is Sarah, and I just have one thing that I would add. So Julia has been referencing that the full reports will be available, and we will encourage all of you to read those and utilize those reports. A summary report will definitely be included in the Title V application and annual report that will be posted for public comment in most likely late May, early June. And the full assessment report will either be available with and linked to that application or will be available later in the year once we submit the final Title V application. So we will be sure to communicate about when the full needs assessment report is available for review.
Thank you. Any other notes in the room?
This is Dawn. I'll just say one quick thing. I think that all of you who've been a part of this process and that are viewing this webinar today, it's very obvious that I believe that we did an excellent job in the state of Michigan this year, garnering input from a very broad cross-sector of families, communities, and professionals. and in the larger landscape of Title V across the country. I think Michigan definitely excels in this area, and that's going to be noted by HRSA when they see our needs assessment reporting.
Thank you.
I guess I would just add that in for Children's Special Health Care Services, this has really prompted us to look at evaluation as a critical component, and to go ahead and be working with the National Center for Maternal Child Health Workforce Development in order to develop an evaluation plan so that we will be able to, on an ongoing basis, report on indicators and collect the types of data and be able to stratify that data the way we feel we'll need for future needs assessments.
Thank you. Thank you. And I think that feeds well into the next section of the webinar here, which is what do we do with all this data? And many of you on the phone were gracious enough to work with us on figuring out what all of this means. So once we went through the process of gathering the data and identifying themes within the data, we brought that data forward to 3 domain-specific work group meetings to present results. So we brought together women, maternal and infant health stakeholders, child and adolescent health stakeholders, and children with special health care needs stakeholders in 3 separate groups to look at the data related to that population domain and help us figure out what does all this mean? What does this tell us about the most pressing needs facing this each of those specific populations, as well as MCH broadly? So we went through a day-long facilitated process, as many of you will remember, to look at the data and figure out priority need statements related to each of the major themes that emerged from each of those population domains. Those day-long sessions, I just want to acknowledge and thank and show deep appreciation to everyone who was involved in those conversations. They were intense and long days. You processed a ton of information during those conversations and did so in a way that I felt was very true to the data that you saw in front of you and very authentic to what our intention was behind the process of gathering this data and bringing it forward to telling us about need. So just want to acknowledge and thank all of you who were involved in that process. It was really inspiring to see, and I'm sure you all left those days pretty tired from all the wonderful work and thinking that you did. So after those 3 days were over, we had over 50 priority need statements. Those priority need statements were presented to the Title V Needs Assessment Planning Committee to kind of think through how do we want to handle what we learned through this process and what these groups told us the needs were from the maternal child health populations in the state of Michigan. In looking through those needs, there's a couple things that we noticed as a planning committee. We noticed that there was nothing that came out of the process that didn't feel like it was important, that didn't feel like it was a priority, that didn't feel like it needed to be carried forward in some way. We also noticed that there was a good bit of overlap between the groups and some of the needs that were identified. Our process was really not designed to figure out those cross-cutting needs. It was designed to look at the population domain specific needs. And yet, what you told us out of those groups is that across these population domains, there are some really common needs that could be thought of in that sort of a way. So what we did as a group is that the domain leads in that planning committee looked at the needs and categorized those need statements around where we saw some of those commonalities across population domains and created kind of a consolidated list of need statements. Our next step was to take those need statements and look at where they fit within the Title V structure, as well as where they fit within other maternal child health spaces within the state. So as we went through that process of thinking about where does this fit, what fits within Title V and what fits somewhere else, we ended up creating these 5 buckets where every one of the need statements eventually ended up living. That first bucket is our Title V priorities. Those will be those priorities that are carried forward into the Title V block grant application and have been linked to national performance measures and state performance measures, kind of in accordance with the structure laid out by HRSA. Also carried forward into the block grant application itself are what we noted as Title V pillars. These are statements that that really can be applied to any work that happens in maternal child health, any work that happens in public health, and certainly any work that happens in the block grant. So the intention around those pillars is to think about how for each of the priorities and each of the performance measures can we incorporate this kind of principle or thinking into that work. We also identified a couple priorities that really suggested an improvement to the needs assessment, where at the end of the process, what was noted is that there was a gap in what we did that, that we need to work on and improve in the next round. We also identified priorities that fit within MCH, but outside of the space of the block grant structure. And those are labeled as MCH priorities. So things we think should be elevated and worked on in the MCH space, but not necessarily through the context of Title V block grant funding. Many of them are connected with existing efforts that are happening or could be connected with existing efforts in the future. And we're thinking about how those could be carried forward in those other spaces. We also identified priorities that really reach beyond maternal child health and into the space of public health work and the work of other sectors, social services, human services, education, transportation, housing, employment, all of those spaces where in order to make that progress, what we probably need to do is partner and work together in those other spaces. So we have that bucket of priorities to elevate beyond Title V, and we have some ideas of spaces and ways that elevating can happen. So having said all that, let's dive into the priority needs in each of those kind of buckets that I just described, starting with the Title V priority needs. So these are the priority needs that will show up in the Title V block grant application for fiscal year 2021 through 2025, which is just crazy to say. But they'll show up there, and it'll create some structure for that work in the next 5 years. So the first priority, develop a proactive and responsive healthcare system that equitably meets the needs of all populations, eliminating barriers related to race, culture, language, sexual orientation, and gender identity. Our second priority need for Title V, improve access to high-quality community health and prevention services in the places where women, children, and families live, learn, work, and play. Our third priority, ensure children with special health care needs have access to continuous health coverage, all benefits that they're eligible to receive, and relevant care where they learn and live. Number 4, expand access to developmental, behavioral, and mental health services through routine screening, strong referral networks, well-informed providers, and integrated service delivery systems. Number 5, improve oral health awareness and create an oral health delivery system that provides access through multiple systems. Number 6, create and enhance support systems that empower families, protect and strengthen family relationships, promote care for self and children, and connect families to their communities. And 7, create safe and healthy schools and communities that promote human thriving, including physical and mental health supports that address the needs of the whole person. So I hope as I read those, you see your words and your ideas and your conversations reflected in the words that are on the screen and in the guidance that you've given to Title V for what to work on over the next 5 years. The next slide describes the Title V pillars. So again, these are the priority needs that we believe could be incorporated into the work under each of those priorities I just listed and well beyond that. But the intention is to build these into the block grant application across each of the population domains, across each of the performance measures. So the first, build capacity to achieve equitable health outcomes by understanding and addressing the role of implicit bias and macro-level forces such as racism, gender discrimination, and environmental degradation on the health of women, infants, children, adolescents, and children with special health care needs. The second pillar, intentionally and routinely find opportunities to seek the knowledge and expertise of communities and families in all levels of decision-making to build trust and create policies and programs that align with family and community needs. And third, deliver culturally, linguistically, and age-appropriate health education that reflects customer feedback, effectively uses technology, and reaches multiple audiences. So again, those are things that we believe connect in well with all of the work of Title V and more broadly. This next slide describes the MCH priorities. So again, these are priority needs that, that fit well within the role of maternal child health, but outside of the structure of the block grant. So these are first, to improve service delivery systems to better identify and meet the basic needs of families. Second, expand educational and advocacy efforts to address the needs of children, adolescents, and families. 3, decrease stigma associated with using publicly funded health and community services. 4, support economic and social conditions that help Michigan families thrive, such as living wage, paid family leave, housing and transportation, and so forth. 5th, establish a workforce that represents the families served to provide prenatal and postpartum parenting education and support. 6, implement primary care prevention strategies at the individual, relationship, community, cultural, and systems levels, while concurrently supporting trauma survivors to support the health and well-being of women, mothers, and infants. 7, eliminate racism and other forms of oppression at the individual, community, and systems level. 8, expand cross-sector partnerships to improve health across population domains to include businesses, political leaders, religious organizations, civics groups, and other partners. 9, integrate systems of care across physical, oral, and behavioral health services to meet the current and emerging needs of all children and adolescents, regardless of race, culture, language, sexual orientation, or gender identity. And 10, regularly provide opportunities for affordable, subsidized, accessible, and high-quality respite care for families and caregivers of children and youth with special health care needs. So across these MCH priorities, the thinking is that there are many of these that connect in with other efforts that currently exist within MCH, but outside of the block grant, or could potentially drive the seeking of additional resources of programmatic activities moving forward outside of the structure of the block grant, but still in the world of maternal child health in the state. And here we have our priorities to elevate beyond Title V, beyond MCH, that really speak more broadly to the needs of all people beyond the maternal child health population. So we heard about several things that we thought were really cross-cutting and required partnership and collaboration across systems in order to make progress. And these are those things that were identified. So first, create systems of care that focus on the whole person and integrate physical, mental, behavioral, and oral health care. Design a care delivery model to meet the unique needs of rural populations. Eliminate funding or payment as a barrier to receiving physical, oral, mental, or behavioral health services or medications. Increase the accessibility and availability of behavioral and mental health services. Break down administrative and funding silos that limit collaboration and create system fragmentation. Abolish racism and other forms of oppression in order to eliminate persistent health disparities and assure equitable opportunities and outcomes. Apply equitable distribution of income to improve child and adolescent health inequities. Engage and empower from the inside out in a nonpartisan fashion through grassroots advocacy. Design employment and income supports that reduce the impact of income inequality on the health of infants, children, adolescents, and children with special health care needs. So again, I hope across all of those needs, you heard, you felt the attention to the needs that you discussed as you were part of those population domain meetings. And hopefully this gives you a sense of where those are landing in thinking about what to move forward within Title V as well as outside of Title V. So this slide just gives you a couple of ideas about some of the spaces where the priorities that were identified as being really critical, but outside of Title V, where that work is headed. So one space that we see for especially those priorities that that need to be elevated outside of maternal child health and Title V, one place to elevate those is through the state health assessment. So the Public Health Administration right now is undergoing its state health assessment and will be beginning its state health improvement plan in the fall. And those findings are a perfect kind of place for some of this work to land and seeing where they align with what the state health assessment tells us and using them to inform what the state health assessment looks like and sets forward as priorities. The Mother-Infant Health and Equity Improvement Plan is a really great space for some of those MCH priorities to fit and be moved forward. They align with the ideas in that plan and create space for moving forward some of those priorities. The Home Visiting Needs Assessment is also kicking off right now and provides a space for some of those MCH priorities to move forward. So ultimately, in addition to these couple ideas, there are other germinal ideas, I think, happening across the MCH partners that have been really deeply connected with this work. And our hope is that it can connect these needs, these priorities, can connect in well with all of your work, that it can create some language, some ideas, linked to some data, and linked to a robust and engaged process that help you in your work talk about what needs look like in your community across the state for the people that you serve and the services that you're connected with in useful ways as you think about what your work looks like moving forward. So our hope is that all of this is beneficial across the MCH system and beyond, in addition to being useful in the context of Title V. So I'm going to pause there for a minute to ask if there's anyone in the room who has any points that you want to contribute that I might have missed or looked over in my rushing to share all of that. Okay, I'm seeing heads shake. Please feel free to enter in the chat. Have we had any chats come through? Okay. If you have questions, if you have comments, if you have anything that you want us to be thinking about as we move forward with this work, and especially if you have an answer to this question and what other ways this needs assessment can be beneficial, please enter those in the chat and let us know what your thoughts are. We're eager to hear from you and are very hopeful that this is the start of a conversation about how this work can inform the system as a whole. With that said, I'll turn it back over to Sarah. Oh, thank you.
Hi, this is Samia Nasser from University of Michigan. Can you hear me?
Yes, I can. Thank you.
Oh, that is an unbelievable amount of work that you guys went through. So I'm very appreciative on behalf of all my patients of what you've done. The question I have is that I know that I don't know if you're the right area to ask the question to, but for transportation for families, I've been having struggle with that with patient because our patient come in from all over Michigan, and some of them like have an appointment at 7 in the morning or 8 in the morning, and they have to wake up at 3 in the morning to come in. And there was service before that they can come in the day before. Is that your area or it's a different area?
It would depend on who your patient is and their age and what program they're eligible for. Okay. If they're on Children's Special Healthcare Services, we would assist with transportation, and you could work through your local health department in order to figure out what those transportation options are. And if it's not, if it's an adult, there's specific transportation providers and or working through the Medicaid health plans if those clients are Medicaid eligible. So if you'd like, we could take this question offline and I'll type in what my information is, and then you could go ahead and you could, I could follow up with you.
Okay, great. Thank you.
Thank you. Thank you for your question, and certainly your question echoes feedback that we heard in the needs assessment process around barriers and limitations to transportation that look different depending on who the family is and what the need is, but are very common and something that that is an important focus moving forward.
We have another question in the chat from Teresa. To what degree will the needs assessment inform contracting with Medicaid health plans?
That is an excellent question and an excellent space to move forward findings to other partners and in other spaces. The focus right now has really been how do these findings show up in the Title V block grant, but I think the next step for us is to think about where are they useful and helpful and informative in other important state level partnerships, which is absolutely, I think, reflected in your question. So thank you for that concept and that suggestion to move some of this work forward into that space. Any other questions coming in? We'll keep them coming as we move forward and share a little bit about kind of our first step of planning based on these results, which is in the space of planning for the Title V block grant application that'll be due before we know it.
Yes. Thank you, Julia, for leading us through a discussion and an overview of those several buckets of where all of the findings from the needs assessment landed. So the next few slides, I'm going to share information about how the needs assessment findings will specifically inform the Title V application, which, as Julia mentioned, is due this summer. And so, again, just to provide some context, I will share a few of the Title V block grant requirements that you can see on the screen now. So essentially, states must identify 7 to 10 state priority needs across the 5 population domains that we have been discussing. So that slide that Julia first went through that says Title V priority needs at the top, those are the 7 state priority needs that Michigan has identified for the next 5-year cycle. States must then link each state priority need to either a national performance measure, which is set by HRSA, or state performance measures. And a minimum of 1 distinct NPM, or national performance measure, must be chosen per population domain. And I will dive a little deeper into that in the next slide to give more context for what that means. And then also to note that states can, and Michigan has, created state-specific state performance measures, SPMs, to address state-specific MCH needs. So first, I'm going to walk us through the NPMs, again, the national performance measures, to share with you where Michigan as a state has landed based on this most recent needs assessment. So first, just to provide the context for this chart that is in front of you, you can see along that far left-hand side 15 national performance measures as designated by HRSA. You can also see to the right of that the 5 population domains that HRSA also sets for states. And you can see that for some of the national performance measures, they link to one population domain. For example, that first one, Well Woman Visit, links to the women and maternal health domain, and others, such as number 13, the preventive dental visit, links to multiple domains. And so I would just note that the X's in this chart indicate where HRSA has identified an NPM links to a population domain. So those linkages are set by HRSA, not individual states. And so just to walk through so that you can see where Michigan has determined to what HRSA calls retire NPMs, which NPMs we are retaining from our current cycle, and then which we're adding. So you can see in the women and maternal health domain, we plan to retire the Well Woman Visit and add the low-risk cesarean delivery measure. We will also be retaining the preventive dental visit for women measure. In the perinatal infant health domain, we will be retiring the risk-appropriate perinatal care measure and retaining the breastfeeding and safe sleep measures. In the child health domain, we will be retaining the preventive dental visit for children. In the adolescent health domain, we will be retiring the adolescent well visit measure and adding the bullying measure. And lastly, in the children with special health care needs domain, we will be retaining the transition for children with special health care needs measure. And so I would just note that as part of the assessment process, all 15 of these NPMs were looked at. Some of the criteria that Julia mentioned earlier in terms of measures with significant disparities, measures that are trending in the wrong direction, or in which Michigan is underperforming the US. We looked at those criteria, and then we also looked at additional criteria, including which measures are the majority or the most local health departments implementing. Where do we have Title V program capacity to implement and impact? Where are there funding needs or gaps? And then is it an MD-HHS priority? And so those were some of the criteria, along with, of course, the overall needs assessment findings that went into decisions about choosing these NPMs for, again, the fiscal year 2021 through 2025 cycle. So I will provide a bit of context for this slide and then hand it back over to Julia and the domain leads. And I would also note that you have this slide as a handout. So if you would like to print that out or have a bigger, more user-friendly version to look at, please go ahead and do that. This chart in front of you essentially shows the linkages between the priority areas, the performance measures, the state priority needs. So as I mentioned a couple of slides ago, each state priority need must link to an NPM or an SPM. And again, that each NPM must have a unique population domain associated with it. So you can see in this chart the NPMs that I just walked through, including the new NPMs. And then you can see on the second half of the chart, the state performance measures, or SPMs. I would note that Michigan did not retire any of the existing SPMs. So the measures around childhood lead poisoning prevention, immunizations for children and adolescents, and medical care and treatment for children with special health care needs, those were all retained. And 2 new SPMs were added, again, based on the needs assessment. So with that, I will hand it back over to Julia and the domain leads to do a little bit of a deeper dive into this chart.
Thank you, Sarah. I will say as I dive into this part of the conversation that probably from day one of the process, this was the step that we had the most worries about, that we knew we were embarking on a needs assessment that would give us findings that told us about the deep, important, critical needs facing the populations that we serve across the state, that we wouldn't get kind of surface level things, that they would be big, they would be broad, they would be critical. And then we knew we would have to line them back up with a handful of performance measures that are created within the structure of the block grant, that's a necessary part of the process. So as I talk through this, we observe that there are, that the performance measures themselves are give a limited view into what we know the needs are. That changes in the performance measures would hopefully be a signal of progress related to that need, but they don't encompass everything that needs statement is about. So we see that and we recognize that, and we're aligning with the structure of this particular funding stream in the kind of best way that we can. So with that said, let's look at that first performance measure, NPM2, and this is a women and maternal health performance measure, the percent of cesarean deliveries among low risk first birth. And we're linking that to the state priority need of developing a proactive and responsive healthcare system that equitably meets the needs of all populations, eliminating barriers related to race, culture, language, sexual orientation, and gender identity. Jumping down in the women and maternal health column down to NPM 13, preventive dental visit, One of the priority needs that we heard was to improve oral health awareness and create oral health delivery systems that provide access through multiple systems. And we're linking that with this NPM 13, which actually includes two parts. The percent of women who had a dental visit during pregnancy and the percent of children ages 1 through 17 that had a preventive dental visit in the past year. Because that NPM has two parts, it actually falls into two population domains, women and maternal health as well as child health. If you look a little bit further down in the maternal and women's health column, you'll see that there's a state priority need identified around intended pregnancy. And this measure is linked to the priority need of developing a proactive and responsive healthcare system that equitably meets the needs of all populations, eliminating barriers related to race, culture, language, sexual orientation, and gender identity. And here what we'll be measuring for the first time in this 5-year cycle is the percent of women who had a live birth and reported that their pregnancy was intended. There are also two performance measures that fall in the space of perinatal and infant health, breastfeeding and safe sleep. Those are linked to the state priority need of creating and enhancing support systems that empower families, protect and strengthen family relationships, promote care for self and children, and connect families to their communities. The group that identified that priority need when they were looking at data related to breastfeeding and safe sleep, that was kind of the space that they landed in around what needed to be done. So it made good sense in this case to link it back to those two measures related to breastfeeding and safe sleep. Dawn, I will pause there for a second to see if there's anything that you want to add around those linkages.
Absolutely. I'd first like to point out and reemphasize what Julia and Sarah has said regarding the fact that we use both qualitative and quantitative data to arrive at these areas of focus while staying within the Title V requirements in space. So by no means is this all inclusive of all the great input that we heard. But as was mentioned, our broader public health and maternal child health efforts will be working to address all the areas that we heard. So specifically to these first two domains, we, based on focus group information that we heard as well as data, Lindsay is here from our maternal child health epidemiology area. We have strides that we can make in the area of low-risk cesarean delivery, and particularly related to disparities that exist in this area. If you want to say a couple words.
I can actually pulled up that slide. I was like, oh boy, okay. So what we saw as we looked over the last 6 years of data on the rate of low-risk cesarean delivery in Michigan is we saw two really concerning things. The first is that Michigan has consistently had a higher rate of low-risk cesarean delivery than in the U.S. as a whole over that time period, typically a difference of about 3 percentage points. And in this case, the low-risk cesarean delivery is defined as one of a single infant who's in a head-first position at full term to a mother who's not given birth before, and doing a cesarean under those conditions is considered inappropriate care. So that was sort of the first issue, is Michigan's consistent higher rate of low-risk cesarean delivery. The second issue was that while we saw among the white mothers a consistently declining proportion of low-risk cesarean delivery, what we saw among Black mothers was a little bit more confusing, a lot of jostling around the same couple of percentage points, but nevertheless consistently higher than white women for pretty much every time point since 2012. And with a trend line that has been increasing since 2015. So while white women's rate of low-risk cesarean delivery has been decreasing, Black women's has been increasing since 2015. So those two issues there were sufficient to really concern us from the data end.
Thanks, Lindsay. And then next we move to breastfeeding and safe sleep. And throughout all of our work, we know that infant nutrition is so important to both mom's health as well as the baby's health. And this is an area in Michigan that we've made great strides, but we still have a ways to go. So given the fact that we know the improvements
that exist for health and social outcomes as a result of breastfeeding, and the fact that we have a lot of momentum that's built in Michigan, this is definitely an area that we need to keep moving forward in. Infant safe sleep, again, this is an area that we've had a lot of great work around with our local partners and community organizations, but we also know that the deaths of infants as a result of unsafe sleep environments is an area that we can do much better in. And given that these are preventable deaths, again, this is an area that we most definitely need to focus on. Preventive dental visits. Again, we've created a wonderful infrastructure in the state of Michigan, but we have so much more work to do. So again, this is an area that we can continue charging forward on, given the evidence of improving health, well-being, and outcomes. And then finally, intended pregnancy. Again, this is an area that all these areas we're doing great work in, but we definitely achieve much greater improvements, and particularly around improving both pre and interconception health for families, as well as assuring that the ability to have access to reproductive life planning exists. So with that, I think we're pausing at the end for questions, right?
Yes.
Okay.
Yep.
Thank you.
Yeah. So in our area of child and adolescent health, we also have a series of measures to highlight that are connected in with our state priority needs. So one of the priority needs that emerged for adolescents was around creating safe and healthy schools and communities that promote human thriving. And that is linked to a new performance measure related to bullying, as you can see on this slide. As noted, one of the child health measures is related to dental visits, connecting with our oral health state priority need. And then under our the state performance measures, we have a couple priority needs related to children and adolescents. Expanding access to developmental, behavioral, and mental health services through routine screening, strong referral networks, well-informed providers, and integrated service delivery systems. One space where that work happens of screening and referral and connecting services is around lead testing. And so we have a performance measure related to that area of work. And then improving access to high quality community health and prevention services in the places where women, children, and families live, learn, work, and play. One of our indicators that tells us about the degree to which that's happening is related to immunizations for kiddos 19 to 36 months, where we have some gaps and opportunity for improvement. Finally, we have another performance measure related to adolescents in the space of immunizations as well. So similar to what we see for children, there's some opportunities for strengthening access to high quality community health and prevention services in the space of adolescent immunizations. So with that quick overview, Carrie, is there anything that you'd like to add? Carrie Terry is the domain lead for this group for children and adolescent health.
You may be muted, Carrie, I'm not sure.
Do you hear me now?
Yes.
Okay, sorry about that. Yes, I think, first of all, so much appreciation and thanks to everyone who showed up and participated in our child and adolescent stakeholders meeting. We had great conversations. I think we struck a really good balance of maintaining our commitment to priorities that continue to impact children and adolescents, and also really staying true to some of the emerging data that took up a decent portion of time around mental health. We heard some really compelling data around depression, suicide attempts, suicide completions for adolescents in particular. As Sarah noted earlier, we previously had focused on adolescent well care with the last 5-year Title V cycle, and because of all of the new information and stats and great feedback we got through this process, we switched to the bullying performance measure for adolescents and are maintaining our commitment for preventative dental visits for children, childhood lead poisoning prevention, and immunizations for both children and adolescents. All 4 of those priorities that we are continuing with involve a great deal of interaction and support to local communities. That money for all 4 of those areas goes right out to locals and local health departments to meet the needs of our most at-risk families. Lindsay,
thank you, Carrie.
Yeah, absolutely. Lindsay, was there anything that you wanted to highlight with the data?
I guess the only thing I would really want to add here is that both the bullying NPM and the SPM around behavioral mental health for the adolescent domain in particular, we had findings across so many different mental health and behavioral health related indicators for that population domain that really urged us to do something in that direction. And I think, you know, probably the most compelling is that there's been a 43% increase in students reporting sad or hopeless feelings for 2 weeks, such that they stopped doing their usual activities since 2011 among Michigan high schoolers. And that's just really indicative of what we're seeing, and hopefully we'll be able to move on those.
Thank you both. And for children with special health care needs, as you can see on the slide in front of you, we have 2 performance measures, both linked into the same state priority need, which is ensure children with special health care needs have access to continuous health coverage, all benefits they're eligible to receive, and relevant care where they live and learn. And the performance measures related to that have to do with medical care and treatment, as well as transition. And we have Teresa Christianer here in the place of Lonnie Barnett today, because Lonnie doesn't have a voice. Is there anything that you want to make note of?
No, these are 2 indicators that we are continuing to follow over the course of the next 5 years. We feel that both of these indicators are good indicators. The transition indicator allows us to measure the final outcome of actual pediatric clients that have transitioned to adult care. We all know that that's important because it allows for there to be continuity of care and helps to assure that there is adequate insurance coverage. And then the other one, of medical care and treatment, that too is an important indicator for us as we are looking to measure satisfaction or the patient experience in their ability to access timely and appropriate care. And so we use our CAP survey for that.
Thank you. And you'll note that we have also a cross-cutting performance measure at the bottom of your page here. And this really reflects the very robust, strong, pervasive feedback that we got around this particular state priority need of expanding access to developmental, behavioral, and mental health services through routine screening, strong referral networks, well-informed providers, and integrated service delivery systems. We know that some local MCH funding is directed toward this type of work at the local level, and we think that that's an important thing to highlight. And we also think that there's opportunity to increase support for this type of work within the context of the block grant and within the context of maternal child health. So there's a state priority need that's been added to this structure to reflect the importance of this finding within the context of the needs assessment and the need to do some development in this particular space. Sarah, do you want to speak any more to that? Or do you have a question?
Yep. Are there any measures, this question relates to equity, noting that the measurement, that the measurement frequently mentions equitable access. Are there any measures agreed upon that specifically refer to equity or defines equitable?
That's a fantastic question, and I think one that we've struggled with a little bit as we think about kind of the alignment between the priority needs and the ways that we're measuring those. I think that there's opportunity to think about how else we want to understand progress toward these needs outside of the measurement structure of the block grant, but the structure of the block grant kind of looks at population level outcomes for the population as a whole, which doesn't speak particularly well to equity. So I think that there's space to kind of continue to push our thinking in that way. So thank you for that question.
So we had a question on the slide previously as well, one of which was able to be answered through the chat, but we did have a question talking about the NPMs for all the populations. Is there a reason that adequate insurance is not an NPM for all populations?
So the NPMs are set by HRSA. The NPMs, and we dig into this a little bit in the next slide, but HRSA identified the NPMs based on short or medium, that they define as short or medium term indicators of health behaviors or healthcare access and quality. And so why they decided to link it to those populations and not others, I don't have an immediate answer for that. I would note that this December of 2020, a new 3-year guidance will be coming out. The Title V guidance is issued every 3 years, and the needs assessment is every 5 years. And so we would certainly have opportunity to provide that feedback to HRSA in terms of adding that measure to be across other domains. We've had the same conversation internally around bullying and its relation to child health in addition to adolescent health. So I think that there are a few measures that perhaps states have and could have feedback to HRSA around expanding the population domains that the measure applies to. And also I would note that HRSA chose the NPMs based on criteria including that there was a large investment of resources by the states at the time in 2015 when the Title V transformation occurred, and that a state could delineate measurable activities and or that significant disparities existed among population groups. So those were some of the criteria that were used to determine the NPMs.
Sarah, do you want to speak a little bit to the national outcome measures structure?
Sure, yeah. So this slide that you see in front of you, this is a little bit of a deeper dive, but we thought it would be a good time to share this with you for some additional context. So we know that we've talked a lot about the NPMs, so those 15 measures across the top of the chart there, which are really the focus of the state action plans that states will be developing over the next couple of months as required by HRSA and submitting in our next application. But what we also wanted to share is that all of these national performance measures are also linked to what HRSA calls national outcome measures, or NOMs. So those are the measures that you see along the left-hand side. And again, in this chart, you can see where HRSA links the NPMs to the NOMs, I know it's a lot of acronyms, as a way to really see the relationship between those different measures. And so how HRSA distinguishes the national outcome measures, again, those ones along the left-hand side, is that they are the longer term indicators of population health, and some of the criteria that were used to identify those, it could have been that it was a Title V legislative requirement that data be collected, or that it was considered a sentinel health marker for the MCH population. And then there are a few other criteria. But one thing that I wanted to note is that I think that this chart helps to highlight some of the connections. So for example, if you look at the breastfeeding and safe sleep NPM, so measures 4 and 5, you can see that those are also linked to infant mortality. And we know that infant mortality is an important focus area in Michigan, and a place where there are significant disparities, and infant mortality is certainly a focus of a lot of the work within MCH. Another example would be if you look at the bullying NPM, so that is NPM 9, you can see that that is also linked to the NOM 16.3, or adolescent suicide, which again came up through our needs assessment as a very clear indicator where Michigan needs to do work, and again has disparities among different populations. So this is just to again give additional framework. All of these outcome measures are tracked through our Title V application and annual report, and so all of that data is available for Michigan specifically if you go in and look at our application and annual report. The idea, big picture, that HRSA uses as the guiding framework is that if states are able to impact and make progress on an NPM, that it ultimately will result in positively impacting an NOM. So lastly, and I know we just have a minute left, and so I will just quickly share that next steps In March and April, we will be working with program staff to develop Title V action plans for these NPMs and SPMs, and in addition, completing the full Title V application and annual report, completing the needs assessment report and summary report that's required for the application, et cetera. So there will be a lot of work happening in the next couple of months. And I would just also note that those state action plans include specific objectives and strategies around the measures, and those are the places that, as Julia discussed earlier, we will be working to embed those Title V pillars into the state action plans as well. In May and June, the Title V application annual report will be posted for public comment. And again, we'll include the needs assessment summary report, and then the application will be submitted to HRSA in July. So I know we're at time. I don't know if there are any other questions, or if Dawn, Carrie, or Teresa would like to add anything further.
I don't have anything. This is Dawn. I don't have anything to add further, but we're definitely open to answering questions, even though we're at the 4:31 time mark, if there's questions in the chat box or otherwise. All right.
That looks like it.
Any other questions on the phone?
No, thank you.
Well, with that, our team here at the state and at Michigan Public Health Institute, thanks everyone for joining the webinar today. And we look forward to ongoing partnership and collaboration as we continue to move our maternal child health work forward. Thank you.
Thank you.